Social prescribing, very simply, is a way to connect healthcare and non-medical supports to enhance a person's well-being. This is not a new concept or necessarily a new practice for us in Canada, but what social prescribing at its fullest can offer is an intentional collaboration between health and social care systems, practitioners, individuals, and the community. And it prioritizes and enables a person's ability to determine their own goals and to take control of their own well-being in a supported pathway while tracking data on their journey and the outcomes, and builds a more connected community overall. A number of social prescribing initiatives have emerged in Canada over the last 5 years, and we know that many other programs and projects are similar, just not using the term. So the Canadian Institute for Social Prescribing, with funding from the Public Health Agency of Canada and infrastructure support from the Canadian Red Cross, was founded with the goal of being the national hub where we can connect people and practices and projects and research on social prescribing across different sectors, across different regions, under one big network to learn from each other, to celebrate what everyone is doing, and to advance a common understanding and a national framework for us in Canada. And we are committed to health equity, community leadership, and collaboration in our work together. So I am so grateful, and we are so grateful for the many partners that have already come alongside us, including the awesome Bridgeable team here, who offered very generous support over the summer to build some key foundations. Now, the first phase of their work, which I hope many of you have already read, is a current state map of how social prescribing is being imagined and delivered in different regions in Canada. And I'm looking forward to this report from their sessions with link workers, from community connectors, on some of the key considerations for national momentum. And I want to offer my deep gratitude to everyone who has given their time to help inform the Bridgeable team here. I know that this could not have been produced without community connectors, project managers, community leaders, many of you joining today online, and many others who share their stories and experiences and insights. And I want to thank particularly the co-leads of the social prescribing community practice, which is the Alliance for Healthy Communities, Older Adults Association of Canada, Older Adult Centers Association of Ontario, the United Way of British Columbia Healthy Aging for helping to guide this work. And of course, huge kudos to the Bridgeable team. This is the beginning of our work together as a collaborative network. The findings that will be shared today will be important conversation starters for us. We hope to build on what the Bridgeable team has surfaced to explore and address the complexities, the barriers, and the opportunities together. So if you're interested in continuing on this journey with us, I invite you to check out our website, which is on the screen here, join our mailing list, and stay connected for ongoing conversations. Back over to your Danos and the Bridgeable team for the exciting part of this.
Thank you so much, Sonia, for sharing a little bit more about the work CISP is doing and for giving a huge thanks to all the contributors of this project work. So we do want to share some of those names. We did have many practitioners and implementers from Alberta, British Columbia, and Ontario contribute to this work, whether it was through a one-on-one interview, a workshop, a video reflection, or an offline questionnaire. We are so grateful for all the valuable insights that you shared. This work would not have been possible without your time and contributions. And also wanted to say once again, thank you to the Social Prescribing Community of Practice, co-leads, and the CISP team for the collaborative effort for the last 4 months. Thank you, Sonia, Sarija, and Kate. And thank you to Natasha, Josephine, Pat, and Bobby for attending weekly check-in meetings all summer, reviewing our documents offline, and providing our team with plenty of guidance and support throughout the course of this project. So next, I will share with you a brief overview of our project. So we conducted our project this summer in 3 phases. Our first phase, we set out to capture the current state of social prescribing. As Sonia mentioned, some of that work is now available. So hopefully you will have a chance to take a look if you haven't yet. We spoke to social prescribing experts in British Columbia, Alberta, and Ontario to understand the different service delivery models that are currently being used across different regions in Canada. In phase 2 of our work, we co-created the ideal link worker characteristics. So this is community connectors, navigators, plenty of roles that are doing link worker type work. And we discussed the supports they might need, the practice settings that might be ideal for this work with different practitioners and implementers. We then took our findings from this co-creation and validated what we learned with policy and funding experts. And lastly, we consolidated our project findings into some recommendations for CISP to take forward and consider as they develop a national model for social prescribing. I did want to note some limitations for the work that we did. Given the short timeline, we weren't able to engage with all the stakeholders that are really important for advancing social prescribing. So I just want to mention that there was very limited engagement with certain groups that include social prescribing beneficiaries, so clients and community members and patients who have accessed social prescribing services, as well as stakeholders in provinces outside of and territories outside of British Columbia, Alberta, and Ontario. As well as members of Indigenous, BIPOC, LGBTQ2S, and newcomer serving communities. We also recognize that the future of this work should include broad representation from each of these groups and others. So I'm going to pass it over to Liz from our Bridgeville team to share a little bit more of some of the voices we were able to capture through this project work. Come on over, Liz.
Thank you, Jordanos. All right, so my name is Liz. I was a service designer on this project, and we learned that the value of social prescribing is demonstrated best by sharing the stories of those who are currently involved in the practice. We captured some of their stories through a video reflection series, and I'm going to share with you some of these reflections as told by healthcare providers, link workers, and community partners.
And as family doctors, we often see people with conditions like diabetes, depression, or osteoporosis. Social prescribing acknowledges that people's lives, what influences their health, goes far beyond what happens in the clinic or the hospital. It involves feelings of connection to their community, social supports, ability to pay for nutritious food, caregiving responsibilities, and so much more. And all of these social factors actually form 80% of health.
The impact of a widely spread social prescribing system would allow room for more people to be seen, and because it's important to remember that not all healthcare needs are best met at the doctor's office, that sometimes they are best met outside of the doctor's office with human connection.
And if we were able to intervene earlier by providing them with social prescribing and getting them connected to resources in the community like exercises that might be acceptable to them, food security to ensure they have a healthier diet, and social interactions through joining community programs, we know that all these things lead to a healthier lifestyle and improve the chances of healthy aging.
Social prescribing is meant to offer seamless system collaboration in an effort to improve the overall outcomes of wellness and health in society.
When a client goes for help to a provider, they usually get help with one specific thing. But in reality, our lives are complicated, so there may be something, a social determinant of health that's causing that issue. For example, when you go to a navigator, they'll be able to see the whole picture and see what's causing what, but also see what resources are available so you can get that help as a client.
So we were able, especially to figure out things to do with folks' social isolation and their mental health, and figure out different strategies and ways to help them achieve their goals, no matter how big or small, which would then have a ripple effect to hopefully better the rest of their health.
There's lots of resources available to seniors that they're not aware of. So with the social prescribing program, we can make lots of connections for them, and they have a better quality of life and become happier humans in the community they live in.
I see great value in social prescribing in that it's a very cost-effective way to provide services and supports for people that enhance their health outcomes without really taxing our health systems. So things like Meals on Wheels and homemaking services and lawn care and snow removal and transportation mechanisms. So all of these things combined together are really great ways of helping people to stay in their own homes, helping people to have a rich social life, having people connected to their communities. And in the long run, it's definitely going to help their health outcomes. So I'm a big proponent of social prescribing as a way to help people live better lives and to stay connected to our health system, but in a more proactive way.
Okay, so I hope you enjoyed those stories. I'm not sure if you could all hear them. We had a bit of an issue with our projector, but those will be available online so you can watch them in your own time. And I want to say thank you to everyone who contributed to those video reflections. I'm now going to walk you through our executive summary. So as we mentioned, CISP has begun a 2-year initiative to develop a national framework for social prescribing in Canada. This presents an exciting opportunity to reimagine the way we respond to the health needs of Canadians and enable our health and social service systems to proactively address the social determinants of health. This in turn can alleviate some of the current burden on our primary and acute care services. So through our phase 1 research on the current social prescribing landscape, we learned that many initiatives had someone in a link worker or community connector role. This role is held by a dedicated individual with the capacity to assess client needs, build relationships, refer clients to resources, and provide warm handoffs. We learned that people in these roles work in a variety of practice settings and have varied backgrounds. Through our phase 2 process of co-creation and validation, we explored the core components and characteristics of a unified link worker role. We also explored the challenges experienced by link workers and what resources are needed for their advancement. We learned that link workers must be able to build trust-based relationships. They must have an understanding of the social determinants of health, and they must use a trauma-informed, anti-racist, and culturally safe approach to care. We also learned that link workers need support in the form of ongoing training and professional development, sorry guys, mentorship and administrative support, collaboration with healthcare and community service providers, the ability to collect and share client information, and access to a database of available resources. So we also uncovered a number of health system complexities that need to be addressed in order to scale this unified link worker role. We encountered 3 distinct barriers. The first is the variation in existing patient navigation models. Further assessment of these various models is needed to develop an evidence base and standards for each and learn how the link worker role fits into each model. The second barrier is that unique communities and populations require specific link worker resources and knowledge to address their specific needs. A unified link worker role can pose challenges in adapting to these needs. The third barrier is that primary and acute care services are currently under significant strain, and there are challenges to healthcare funding. It will be necessary to promote the value of social prescribing among different sectors and all levels of government to unlock necessary support for a link worker role. We considered each of these barriers and identified 5 building blocks for advancing social prescribing and the link worker role. And I'm now going to hand it over to Safia, who's going to walk us through these building blocks in the next section.
Thank you, Liz. My name is Safia. I worked as a researcher on the Designership project this summer. So as Liz described, when we started the process of co-creation, we focused on the link worker and the support that they need. We decided to work towards building out a unified link worker role that could be established within the healthcare system, as this is what we saw as central to the progress of social prescribing in the UK, where social prescribing is quite established. But the more we learned about the experiences of link workers and practitioners, we learned about the diversity of services that they provide, and as Liz mentioned, the many health systems complexities that exist. So our building blocks seek to address some of these barriers and support the practical day-to-day functions of social prescribing practitioners in Canada. The building blocks also aim to support collaboration between the interconnected stakeholders and support policy advocacy for social prescribing. The 5 building blocks that we developed are amplify the voices of social prescribing, provide training, support, and resources, create a friendly policy environment, build bridges between healthcare and community services, and measure impact. And each building block presents unique opportunities to advance social prescribing and support the link worker. By amplifying the voices of social prescribing, and by the voices, we mean all stakeholders who participate in and benefit from these programs, this can send widespread messages about the value of social prescribing. This can support the activation of social prescribing initiatives in other regions as emerging practitioners are able to hear about successes and also anticipate challenges. And we also know about the power of storytelling to influence policy. By providing training, resources, and support to link workers and other practitioners, this can respond to some of the practical needs that were identified by link workers. This can build consistency around programs and help practitioners to better serve their communities. By creating widely available training, this can also help newly emerging social prescribing programs to get off the ground. By creating a friendly policy environment for social prescribing, we mean promoting a multi-sectoral approach to addressing the social determinants of health. By supporting buy-in from multiple ministries and getting health promotion on the agenda of non-health sectors, this can expand the reach of social prescribing and support policy change. So we know that successful social prescribing initiatives are relational in nature, which means that there's a lot of collaboration across different sectors. So building bridges between healthcare and community services and focusing on preventative care can reduce the burden on the health system. This can also help us to identify and address gaps in community and social services, and help these sectors all work together to address the holistic needs of patients. Finally, measuring impact is essential to building an evidence base that highlights the value of social prescribing. By developing standardized evaluation and impact tools, there can be consistency in data collection across social prescribing initiatives that can be adapted to community needs and also translated to different audiences. So all of these building blocks are important for advancing social prescribing, and they can be pursued all at once and are all mutually reinforcing. Our research and validation allowed us to uncover key implementation ideas for building blocks 1 and 2. For the remaining 3 building blocks, we've outlined some thought starters for each of these. We've begun to think about what these could look like, some key areas of exploration that need to happen in order to implement each building block. We've included some global and national examples where addressing these building blocks is working well, and also how all of these building blocks advance the link worker role. Today, we're going to be covering building blocks 1 and 2, and you can find building blocks 3, 4, and 5 in our final summary report, which will be published in the coming weeks. But for today, I'm going to pass it over to Emin and Mary, who are going to tell you a bit more about our implementation ideas for building blocks 1 and 2.
Thank you, Saf. So building block 1 is amplify the voices of social prescribing. Safia mentioned that there's great power in storytelling, which is very true, and it's a topic that we found that we were constantly addressing in all phases of this project. By sharing social prescribing stories and successes from practitioners and community members through various platforms, these include online campaigns, podcasts, radio, print media, and in-person events, we can learn how existing social prescribing initiatives are raising awareness. We can also learn how to best engage participants in sharing their own stories. Through publicly sharing experiences, the profiles of social prescribing can be more widespread, and we can promote its value to individuals, populations, and systems. This building block can be used more specifically to help advance the link worker role by supporting role definition and increasing both awareness and credibility of the role. It can also provide opportunities for link workers to share their challenges that they face, as well as expand the social prescribing community of practice. Now we get into a few recommendations to start amplifying these voices. The team came up with 3 ideas to get started. #SPNMe is an online campaign. This movement can uplift the voices of social prescribing during a social prescribing awareness month. That sends call outs to social prescribing stakeholders, including beneficiaries, offers prompts for storytelling, as well as broadcast stories across multiple platforms. It really is an easy and effective way to gather national stories of social prescribing realities and successes. Next, we have the Social Prescribing Boost Bus. This would be led by local story gathering teams and is a colorful bus with audio and visual recording equipment that travels around provinces and municipalities to collect in-depth stories from social prescribing stakeholders, as well as beneficiaries. This is a great way to gather detailed oral and visual accounts of social prescribing beneficiary experiences, which bring the value of social prescribing to life. The last recommendation for this building block is a summer of social prescribing. It's a summer-long series of broadcasted in-person panels and online webinars, which feature social prescribing implementers, beneficiaries, policymakers, and funders in discussion about social prescribing benefits and successes. I'm now going to pass it off to Mary, who's going to talk to you about building block 2.
Thank you, Emin. So I'm going to take us through building block 2, which is provide training, resources, and support. So as Safia mentioned, the need for accessible, standardized training was something that was explored with implementers during our co-creation sessions. And based on those learnings, we've developed some recommendations with the goal of providing both consistency across initiatives, as well as supporting new initiatives with getting off the ground. So we recommend the creation of comprehensive practitioner role descriptions, the standardization of training resources, and further making these accessible on multiple mediums, for example, to accommodate both in-person and remote training. We also recommend providing equity and anti-oppression training to all implementers in order to better serve the needs of their communities. So in addition to supporting initiatives as a whole, providing proper training and resources will also empower link workers to have greater impact in their communities. And standardizing training will increase consistency in service delivery across initiatives, and formalized training and ongoing professional development will build credibility around the link worker role. So what could this building block look like in action? So just like in building block 1, we've developed 3 recommendations for how this might be put into practice. So the first is a social prescribing quiz, which could support in the development of practitioner job descriptions. So this could be available on multiple mediums and allow social prescribing practitioners to share role descriptions and the services they provide, as well as the resources and supports they use to serve their communities. Our second recommendation is a multimodal training guide, which would be developed in collaboration with implementers and could provide interactive training for practitioners across diverse settings and client contexts. And our third recommendation is a social prescribing starter kit. And this could look like an interactive toolkit that could enable organizations to measure the readiness of community partners, choose an implementation or population focus, and connect with peer initiatives for inspiration and mentorship. And this could include an online forum where implementers could share challenges, receive feedback, and share resources. So that concludes building block 2, but as Safia mentioned, there are also 3 more building blocks for which we've developed some early thought starters, and we'll be sharing all 5 building blocks in our summary report, which will be published in the coming weeks. And we're also working on creating an online site, which will house all of the content in this presentation, including all 5 building blocks, as well as the video reflections that we shared from practitioners and our summary report, and also some fun interactive elements. So stay tuned for that. And now I'm going to give folks in person and online an opportunity to ask some questions, and I will pass it over to Jordanos and Emin to facilitate.
Thank you. So, hi everyone. Thank you very much for listening in on our presentation. We'd like to take the next 10 minutes or so to answer any questions that you might have. I think we have one to get us started, but please use the Q&A function to share your questions and we'll do our best to respond to them.
We don't have any questions in the Q&A chat yet, but we'll pause and see if folks have any questions. Feel free to raise your hand or put a question in the Q&A chat, and we're happy to answer those for you. Yes, Davina.
So in terms of, thank you for that excellent presentation. In terms of one of the recommendations was training and learning opportunities. Were you able to identify some core components of what that training might look like?
Sure, I'm happy to answer, and thank you, Samina, for that question. We were able to get some early thought starters on what some of these trainings might look like, and that's something we'll be able to share with the CISP team at the culmination of our project. But some of the things that we did learn was having a 2-tiered training might be optimal, so having something that's standardized for folks more broadly who are doing link work or link worker type supports, and then also having organizational trainings to support individuals who are doing this that are more specific to the communities that they serve. So, yeah. Thank you for that question. All right, so we have a question in the chat. So the question is from Amrita, and what are the sustainability challenges for social prescribing in your perspective? I'm going to do my best to answer that question, and if Sonia wants to jump in and add to that as well. I know we also have Kate in the audience, so Kate, if you want to top up on that as well, I'm happy to have you. But in terms of sustainability, I think some of the things we learned from health policy experts and decision makers was that there are a lot of folks who are doing some form of navigation support or link working support in different health systems and models. So I think a key first step would be to really identifying what's working well across some of these initiatives and where is there an opportunity for social prescribing to really build additional connections. I don't know that we've uncovered the answer yet in terms of what sustainability needs to look like for social prescribing going forward, but hopefully that's a question that CISP will be able to answer in partnership with many of the folks they're working with over the next couple of years. All right, so we have another question. I'm going to let Emma read it out, and then we'll see if I'm the person to answer it.
So our next question is, how do you consider health equity, i.e. supporting people with intersectional identities?
So these are big questions. So again, I don't think that we've surfaced all the answers for this. I think a big part of the limitations for our project work is that we didn't get to dive too deep into priority populations that would really benefit from social prescribing initiatives. I think a big part of the work going forward, again, will be to capture those voices and really see and hear what the needs are of these different communities. And maybe Sonia, if you wanted to add to that. Yeah.
So I think to add to that, I think that was a really great answer. Thank you, Redanos. I also think some of the early things that they pulled out from the link worker and that essential role of supporting and journeying with people in a way that enables the voice and choice, that reduces barriers, that addresses the barriers that people are facing from that trauma-informed and anti-oppressive lens is something that every community connector, link worker, people doing this work and that I've spoken to have identified as essential to how they do their work, but is also something that I think we need to look at supporting going forward with training and some of those, bring those supports around the people. But that's a really great question, and that it's a really essential piece to consider of what makes social prescribing impactful and how to do it well in that way.
Thank you so much, Sonia. And we'll pause again to see if there's any more questions coming in the Q&A channel. All right, so we have an additional question from Chloe Straw, and the question is, do you have a clear sense of how we keep the boundaries of social prescribing clear, i.e. not fall into social work type roles while still receiving broad support? I will do my best to answer a little bit of this from the work that we've done and then maybe have someone else follow on. But I think part of what we learned is that there are many initiatives across Canada who are doing social prescribing work and not necessarily calling it such. So I think a big part of this early work is building collaborations with folks who are doing this type of work on the ground and getting alignment around a common agenda. I think the biggest thing with social prescribing is there's an opportunity to really improve population health. And I think starting with partnership building is a big piece of that, but I'll let Sonia or Kate or anyone else who wants to talk that up also.
Just in here, I guess. I don't have an answer to this, but I think that's the question. That is the work that we're doing together. So the first step of the work is what is already happening. The second step of this work is what do we need to see happen? And then we start to formulate what are the boundaries and structures around this work, including really important insights from people like Chloe, who is doing this work to say, this is how my work is different from the other work that is happening around. So great question. And this is the direction that we are going into together. That I'm very excited about.
All right.
Yeah, comment as well. I think just wearing an implementation hat from a Red Cross perspective is part of the work that we as an organization are doing as well. Prior to the leadership of CISP and our phenomenal CISP team coming on board, we recognize as an organization, not just limited to health service delivery across the country, but also in terms of responding to emergencies, disasters, prevention aspects of disasters, and building resiliency after a disaster as well. There are nuggets of social prescribing that we've been touching through our various services. So apart from the great work that Sonia and her team are doing on CISP, we're also mapping some of the existing services that we provided, how we actually touch on social prescribing, continue to build on that as well. That's just the implementation part of CRC, I suppose.
Thank you so much for that, Samina. I think we have an additional question. All right, so our next question is from Kate, and I might have some of the team jump in on this one, but the question is, what's your team's favorite lesson or learning from the community experts you heard throughout the project? What do you see as the value of starting with community knowledge? I'll see if there's anyone on the team who would like to jump up. Saf? All right, I'm going to welcome Saf up to answer that question for us.
Favorite lessons, that's a really great question. Well, I'll start with the second part. What do we see as the value of starting with community knowledge? I mean, I think that one of the biggest values is identifying, well, what already exists and what the gaps are, what's working well, and where the role needs to be defined a little bit more. I think what we heard a lot during validation is that we need to focus on repurposing and focus on the health system and what's already being done, because there isn't a lot of room in the health system right now to build out a new role. One thing that really stuck with me from validation that someone said is, we can outline what's happening now, we can talk about repurposing, but ultimately it will all, the logical conclusion is it's not enough. And so I would say that the value of starting with that community knowledge and amplifying the voices of social prescribing, which really is sort of, I think, our, I wouldn't say main recommendation, but perhaps the recommendation that really underpins all of them, is that we can show the value of social prescribing. We can show how it can support the health system. We can show how it can improve job satisfaction and service provider satisfaction, the benefits to the community. So starting with community knowledge is really, I think, in communicating the value. I would say my personal favorite lesson is, and learning, is just how passionate this community of practice is about social prescribing. And I think with this kind of energy and love of social prescribing, that I really can see it moving forward in Canada. So for me personally, I would say that is a favorite lesson. I don't know if anyone else wants to share.
Okay, so I'm just going to read the question again, so I have it in my mind. I think I'm not going to directly answer the question, but just my favorite part of this project was speaking with the people that are doing this work, and specifically the link workers, and just learning about the individual impact that they've had on people's lives. And I think the community knowledge is really about listening to what people want, because people know what their needs are and they know what they want for themselves. So starting at that point, as opposed to having a top-down prescription of what people should have, really listening to what they want and then addressing those needs. And we just learned that has had a huge impact on a lot of people's lives.
That works. Great. Thank you, Liz and Sathya, for sharing those thoughts. We do have a couple more questions, and since we have extra time, we can go ahead and answer a couple more. So the next question we have in the chat is, are there some professions better suited to being a link worker than others? Or do you see this not necessarily being a regulated profession? So I think we heard many different things on the project around this. So I think the big key takeaway was that there are some core components that are really important for the link worker role, which we spoke about earlier. So really having an understanding of what the social determinants of health are, being able to build meaningful partnerships and relationships in their community, and also having a sense of what's happening in their community on the ground. So who are the folks in the community and what are their needs? So I think those took precedence from what we heard from different practitioners and implementers in terms of what's really important for a link worker. In terms of credentials, that was something that was a bit more mixed, but for the most part, we didn't gain alignment that, having a particular designation was important, but I think the future of having a link worker role as social prescribing evolves could be really valuable, but I'm also going to let Sonia top up on some of that as well. Okay. All right, wonderful. And then I don't know that we have any additional questions, but I'll pause and see if there's anyone in the audience here that has any questions for us as well. All right, so we have one question in the audience. I'm going to pass over the microphone.
So Designership ladies, what was like your biggest growing point on this project for you all personally? Like where did you feel like the most growth? Because you all come from like research and design backgrounds, and so this is something new for you all.
Thank you, Callie. And that was a question from one of our fellow Bridgeable colleagues, but I'll see if Emma or Mary will have to take a shot at answering that.
Yeah, so I think for me, I think it was getting the opportunity to work with practitioners and implementers and getting to speak with a whole ecosystem of people. It was truly amazing. It's something I didn't have a ton of experience with before. And so I think for me, that was the biggest sort of growing point.
I think my biggest growing point was probably being able to consolidate all of this information, and working with staff has been great, and she really helped me move things forward. So thank you, team.
All right, I'm going to pause one last time to see if there's any more questions, but we are getting quite close to wrapping our presentation for you today. But all right. Well, thank you so much, everyone, for all of your thoughtful questions, and really appreciate you joining us today. Again, this is just a portion of the work that we were able to share with you today. There is our current state report as well, and social prescribing referral pathway that we were able to share just about a week or so ago. So really looking forward to folks having a chance to look at that work, but I'm going to just flash up some of CISP's contact information so that you can definitely stay connected for future work. So if you are interested in learning more about what the Canadian Institute for Social Prescribing is doing, please feel free to check out their website. We look forward to continuing to support CISP and staying involved in the work where we can, but I'm going to invite up Andrea, who's our Managing Director, to also just say a couple closing words as we wrap.
Thank you. Now you're cornered.
Well, you're not going anywhere, so come back here. Designership is a wonderful opportunity for Bridgeable to connect with communities and organizations who we don't typically deliver this type of work with or for. And so we are able to do that through a large investment from ourselves for our Designership team to actually be a part of a paid internship model and give a chance for our people to then lead those types of projects and grow themselves. I'm so proud to say there's so much growth on this team, and everyone has done such an amazing job, and CISP has been amazing with us to coach us along the way and to allow us to continue to push these ideas. It's been a wonderful Designership experience this year, and Jordanis has done a wonderful job as the project lead and leader for everyone here. So congratulations, this is an amazing work.
Thank you everyone for coming and seeing this, and stay tuned. I can't wait to show everything that has been launched and is launching in the coming weeks. Thanks.
Thank you everyone for joining online and in person, but that brings us to the end of our presentation. So hopefully we see you again and hear from you again soon, but have a wonderful Monday from Toronto.